Let's start with our first topic or first section of lecture, hearing loss. And in this, we will specifically talk about conductive hearing loss. While talking about conductive hearing loss, we will pay more attention or concentration on what is conductive hearing loss and what are the size of lesions which cause conductive hearing loss. We will also talk about tympanoplasty and myringoplasty and ossicular reconstruction. So first, the classification of hearing loss. Hearing loss is further subdivided into organic causes and non-organic causes of hearing loss. So organic causes are mainly further divided into two main types, which is conductive and sensorineural hearing loss. As the name shows, conductive is mainly due to interruption or blockage in the conduction of the sound waves, and it mainly involves the external auditory canal and part of the middle ear also, middle ear. So conduction is mainly involvement of external ear or external auditory canal. The other type of organic hearing loss is sensorineural. Again, as the name shows, it's further subdivided into sensory loss and neural loss. So sensory mainly involves the cochlea or cochlear region. Cochlea is the structure present in the inner ear, cochlea. So sensory hearing loss is involvement of the cochlea, and in the neural, again further subdivided into two, peripheral and central. When we say peripheral neural loss, it mainly is associated with eighth cranial nerve, and eighth cranial nerve is vestibulocochlear nerve. So it involves peripheral eighth nerve and it involves central auditory pathways, which is central. So conductive and sensorineural. Conductive is due to disturbance or obstruction in the conduction pathway. Sensorineural is mainly in the sensory path and neural path. Sensory is involvement of the cochlea, and neural is further into peripheral, which is eighth cranial nerve and central auditory pathways. Next, conductive hearing loss and its management. Any disease process which interfere with the conduction of sound to reach cochlea cause conductive hearing loss. So as I mentioned earlier, conductive hearing loss is any obstruction which cause failure of sound waves to reach the cochlea is conductive hearing loss. Some features of conductive hearing loss is Rennie test is negative Rennie test. Rennie test, as I mentioned in the first lecture of ENT, that Rennie test is the test performed to differentiate between air conduction and bone conduction. And in the normal Rennie test or positive Rennie test, air conduction is more than the bone conduction. But when there is obstruction to the conduction, air conduction will be less than the bone conduction, and that's negative Rennie test. So in conductive hearing loss, we have negative Rennie test. Then in Weber test, the sound is lateralized to poor ear. When there is conductive deafness, the sound is lateralized to poor ear. But in sensory neural deafness, the sound is lateralized to good ear or better ear. Then the other finding is normal absolute bone conduction will be normal. Low frequency sounds are mainly affected. So low frequencies are affected more. Bone conduction is better than air conduction, and then loss is not more than 60 decibel. So loss in the hearing is not more than 60 decibel. So conductive hearing loss is due to obstruction in the conduction of sound waves to the cochlea. Certain features is important negative Rennie test, then Weber lateralized to poor ear, normal bone conduction, absolute bone conduction, and bone conduction is better than ear conduction. Again, that's also negative Rennie's test. And loss of sound or loss of hearing is not more than 60 decibel. What are the causes of conductive hearing loss? Etiology is the causes. Etiology is divided into congenital causes, causes which are present at birth. We have meatal atresia, the narrowing or atresia of meatus, opening of the ear canal. Fixation of stapes, foot plate is ossicle or bones in the middle ear. So foot plate of stapes is fixed, is not mobile. Fixation of stapes foot plate, that's also congenital cause. Then fixation of malleus head. Malleus is also ossicle or bone present in the middle ear. Ossicular discontinuity. Ossicles are the three bones present in the middle ear. They are the incus, malleus, and stapes or stapes. So if there is discontinuity or if they are not in conjunction or in continuation, that can also cause conductive hair loss. Continuity of ossicles is important for the vibration and transmission of sound waves from tympanic membrane to the inner ear. So if the ossicles are not functioning properly, then there is hearing loss. Then congenital cholesteatoma is a small tumor or a mass of deposition of cholesterol or wax is congenital cholesteatoma. Then the acquired causes of conductive hearing loss can be in the external ear. And in the external ear, there is usually any obstruction due to foreign body, wax, any inflammation, swelling, any benign or malignant tumor, or atresia of the canal. These are some common causes in the external ear that can cause conductive hearing loss. Then in the middle ear, there is perforation of tympanic membrane due to trauma or infection. That's a very common cause of hearing loss is perforation or a hole in the tympanic membrane can be due to trauma. Infection is also a very common cause of perforation of tympanic membrane. Then there is fluid in the middle ear, for example, acute otitis media, serous otitis media, and hemotympanum or presence of the blood in the tympanic cavity. Then mass in the middle ear due to benign or malignant tumor is another cause of acquired cause of conductive hearing loss. Disruption of ossicles. Ossicles, as I mentioned earlier, can be congenital factors leading to ossicular problems, and there is also acquired causes of ossicular disruption. Can be due to trauma and otitis media and cholesteatoma. Fixation of ossicles due to otosclerosis, tympanosclerosis. Sclerosis is hardening. So whenever there is a hardening of the bones in the ear, or there is hardening of the tympanic membrane, it can lead to adhesions or fixation of ossicles. Then also eustachian tube blockage. If there is blockage, a eustachian tube is a tube that connects the throat with the middle ear. So if there is blockage of that tube, it can also cause conductive hearing loss, and it can be due to infection in the middle ear that cause otitis media, can be due to retracted tympanic membrane. Next, hearing loss in different lesions of conductive apparatus. If there is lesion in conductive apparatus, which is external ear and then the middle ear, it can cause a conductive hearing loss. So what are those different lesions? Usually if there is complete obstruction of the ear canal or external auditory canal that ends at the tympanic membrane, the hearing loss is about 30 decibel. If there is perforation of tympanic membrane, the hearing loss is about 10 to 40 decibel. Ossicular interruption with intact drum, usually 54 decibel. Ossicular interruption with perforation, 38 decibel. So if there is intact drum, it plays an important role. If there is perforation of drum, the hearing loss is more as compared to the intact drum. Malleus fixation, 10 to 25 decibel. Closure of oval window is 60 decibel. So that was all the causes, and there how much is the hearing loss. Next, how it is managed, management of conductive hearing loss. Removal of canal obstruction. If there is any obstruction, that should be removed. If there is wax, is very important cause of obstruction. So wax should be removed. If there is any foreign body, that should be removed. If there is any growth, that should be removed. So removal of cause of obstruction can fix the problem. Then like wax, foreign body, osteoma, mass, tumors, or meatal atresia. Next, if there is fluid is due to otitis media or any other infection or inflammation. Removal of fluid should be done, and that's done by myringotomy. Myringo is the other word used for tympanic membrane. So tympanic membrane is also known as myringo. So otomy is opening or cut. Myringotomy, cut in the tympanic membrane to remove the fluid with or without grommet insertion. Grommet is a small tube that is inserted inside to remove the fluid. So simple myringotomy with or without the grommet insertion. Then next is removal of mass from the middle ear. If there is any mass, it should be removed. And the procedure, how it can be removed, it can be by tympanotomy and removal of small middle ear tumor or cholestoma behind intact tympanic membrane. So how we can remove the mass from the middle ear? For middle ear, we should go through the tympanic membrane, and tympanotomy is the opening of tympanic membrane, and any obstruction, any mass, any tumor can be removed by that procedure. Next is stapedectomy. Ectomy is removal. Otomy we used for opening or cut. Ectomy is removal. Stapedectomy is the ossicle steps is removed, or if there is problem in there. So stapedectomy. Ossicle autosclerotic fixation. If the foot plate of steps or stapes is fixed, it can be removed, and that can be done by stapedectomy. Tympanoplasty. Plasty is the word used for repair. So repair of the tympanic membrane if there is any perforation or hole due to trauma, infection. So tympanoplasty. Repair of perforation, ossicular chain, or both by tympanoplasty. So all these are very, very commonly performed procedures in ENT. So myringotomy, tympanotomy, stapedectomy, removal of fluid, repair of tympanic membrane. So very common procedures performed in ENT. Next, hearing aid can also be used if nothing is helping and still person has problem in hearing. Hearing aids can be tried. So where surgery is failed or not possible. Next is the tympanoplasty. Tympanoplasty is the operation to eradicate disease in middle ear and to reconstruct hearing mechanism. Tympanoplasty is the meaning repair of the tympanic membrane. So it can be performed to eradicate any disease in the middle ear, and if there is any problem in hearing mechanism, to reconstruct that hearing mechanism. Tympanoplasty, surgically restoring hearing. It's process or procedure used to restore hearing. Must have an intact tympanic membrane, ossicular chain, 2 functioning windows, acoustic separation of 2 windows, functioning eustachian tube, and functioning sensorineural apparatus. So for normal hearing process, we should have all these functioning properly. This is the reconstruction of hearing mechanism. So we should have an intact tympanic membrane, good functioning ossicular chain, 2 windows, good functioning oval and round window, then separation between 2 windows, acoustic separation of the functioning eustachian tube, functioning sensorineural apparatus, which is the cochlea, cochlear duct, nerves, all that should be in proper functioning condition. Types of tympanoplasty, we have myringoplasty, tympanoplasty, and ossiculoplasty. All these, myringo and tympano are pretty much the same, and ossiculoplasty is the repair of the ossicles, which are the malleus, incus, and stapes. These are again different surgical procedures or steps of the tympanoplasty depending on where the problem is and what is the problem. So type 1, it's myringoplasty because it's mainly the tympanic membrane is fixed, or there is a repair of the tympanic membrane in type 1, myringoplasty. So tympanic membrane is repaired. In type 2, if there is erosion also of the malleus ossicle malleus, then type 2 is performed, and then type 3 is, as the name show, myringostapediopaxy. Paxy is fixing or bringing down, paxy. So in this, tympanic membrane and along with malleus, stapes is also affected, and there is erosion of stapes also. So along with tympanic membrane, there is fixation of stapes. In type 4 also, there is stapes is fixed and footplate of stapes is fixed. But in 5 it's fenestration, and there is fixation of footplate of stapes. In type 4 it was not fixed. So these are the different steps of tympanoplasty, in which the tympanic membrane along with the ossicle bones are repaired and fixed. Then in myringoplasty, myringo, as I mentioned, is the same as myringoplasty is also repair of tympanic membrane. 2 types of procedures are used for this myringoplasty. We have underlay technique, and overlay technique of tympano or myringoplasty, and the difference is depending on the annulus, anterior annulus. In underlay, the graft is under the anterior annulus, and in overlay technique, the grafting is above the anterior annulus. So that's the main difference between the two procedures. As the name show, underlay is under the anterior annulus. As you can see in this picture, this is the anterior annulus, and the graft is below the anterior annulus. And in this, the graft is above the anterior annulus, and it's called the overlay technique. Next, ossicular reconstruction. Ossicles are the 3 bones in the middle ear. Their proper function is important for the transmission of sound waves. Without the ossicle, sound is not transmitted to the inner ear. So ossicular reconstruction is important to reach the sound from tympanic membrane to the labyrinth. Labyrinth is the inner ear. So we have the, one should ensure for ossicular reconstruction that middle ear is healthy and free of mucosal disease and cholestoma. Eustachian tube function is good. Atelectatic middle ear show poor eustachian tube. So ossicular reconstruction, ossicles are present in the middle ear. So for reconstruction and repairing of ossicles, it's important that middle ear is healthy and is free of any cholestoma. Eustachian tube should be in good functioning condition, and there should be no atelectasis of middle ear. Again, these are the 4 steps or 4 types of ossicular reconstruction. In first is there is malleus and stapes assembly. Then in B, malleus, footplate of stapes assembly. In the third, we have modified incus connecting tympanic membrane to stapes head. And then in the 4th type, we have modified incus connecting tympanic membrane to stapes footplate. So these are different. In the first, we have malleus and stapes assembly is done, then malleus and footplate of stapes, and then modified incus connecting tympanic membrane to stapes head, and then we have modified incus connecting to footplate of stapes. So these are the four different types of ossicular reconstruction. Material for ossicular reconstruction, different materials are used for ossicular reconstruction, and can be performed. Why we need ossicular reconstruction? It is performed when there is trauma that can lead to disruption of ossicles, if there is fixation of ossicle, if canal wall down procedure, when there is no mucosal disease or cholesteatoma. These are the some types of grafts used for ossicular reconstruction. We have autograft, allograft, and homograft. Autograft is a graft which is obtained from the own body. Allograft is the graft which is obtained from the other person but of the same species, and homograft are the graft obtained from the cadavers in different species. So autograft material is incus, head of malleus, and cortical bone from mastoid. These are the materials for autograft. Risk of harboring disease. They are low cost and easily available. So autografts are low cost because the patient is the donor, person is the donor, and they are easily available. Allografts usually are materials are plastipore, polyethylene sponge, hydroxyapatite implants, titanium implants, glass isomer, Teflon prostheses. So these are all different types of allografts. They are ready-made, easy to store and use, but they are costly. So it's that's the disadvantage of allograft, that they are costly but they are easily available, ready-made, and they're easy to store and use. Then homografts are preserved ossicle only, ossicle with tympanic membrane, and they are very difficult to procure, and risk of disease transmission is more with the homograft. Next, different types of prostheses. We have centered, here in this picture, centered, offset types. Then we have titanium TORP and titanium PORP. So, incus, different types of prostheses. We have incus prosthesis, incus stapes prosthesis. This one, partial ossicular replacement prosthesis, and total ossicular. Partial ossicular, some parts of the ossicles are replaced, but in the other type we have total ossicular replacement prosthesis. So this is for the total replacement, and this is partial replacement, center and offset types. So these are the different types of prosthesis available for repair or reconstruction. Incus prosthesis, incus stapes prosthesis, partial and complete ossicular replacement prosthesis. So that was a lot about conductive hearing loss. We talked about the type, where the lesions are, and what's the management of the conductive hearing loss. Thank you for watching sqadia.com.